Hi, I'm Dr. Farah Kamangar, and welcome to the Future of Dermatology Podcast. We're here to talk about the real science behind skin, the medical breakthroughs, the cosmetic innovations, and everything in between.
We are so excited to be back today with dermatology legend, Dr. Larry Eichenfield. Within the dermatologist, he needs no introduction, but for any non-derms listening, Dr. Eichenfield is the Chief of Pediatric and Adolescent Dermatology at Rady Children's Hospital, San Diego, and Professor of Dermatology and Pediatrics and Vice Chair of the Department of Dermatology at UC San Diego School of Medicine, and has pretty much taught us everything we know about pediatric dermatology. Thank you so much for joining us, Dr. Eichenfield.
It's my pleasure to be part of this. Thank you for having me.
And we chatted about, you spoke at SF Derm and again taught us so many things about atopic derm, new topicals, therapies. And one thing you touched on briefly, because the lectures are short in that setting, was topical steroid withdrawal. And you mentioned, well, there's more I could say about this. And anytime you say that, we are going to bug you about more about that topic. So that's what we're going to talk about today, because we find there's definitely a gap in our education about kind of the systematic review of how do you know when your patients have this, catch it earlier, what to do. So thank you so much for teaching us about that today.
My pleasure. So let me start off. So, first of all, the topical steroid withdrawal has become quite controversial. And I think it's because I'll start with the takeaway. There truly is topical steroid withdrawal. It generally is associated with prolonged use of super potent or very potent topical corticosteroids, and is followed by a rebound effect that can be local or can be more extensive than local. And there are certain findings that can be seen with significant topical steroid withdrawal. But I say it's controversial because it has been folded into concerns about topical steroid use, which include our traditional concerns about overuse impacting on normal steroid levels with absorption in more potent topical corticosteroids, or our, the atrophy telangiectasia you can get topically. But it's been folded into this concept that topical steroids can't be used without withdrawal phenomena. And then in a group that was really trying to promote knowledge of some of the problems with topical steroids, the use of language that really talked about topical steroid addiction, and that has been taken up by people and creates the situation where, while topical steroid withdrawal is a significant phenomenon that dermatologists should know about and be able to recognize, there's probably a way, way bigger issue with people who are concerned about topical steroid addiction without a clinical situation that's consistent with that, like someone who's used I have children, they've used 15 grams of topical steroids in their life over 7 months, and the family's concerned about topical steroid addiction. It doesn't follow with that. So that's the sort of background to get beyond the controversy. At least we can explain some of the reasons of the controversy, but at least discuss the sense of where we're at with particularly topical steroid withdrawal phenomena and in atopic dermatitis patients.
No, that's so great to cover first, because there's so many aspects of it. One is just the education of us knowing how to recognize it and treat. The other is all the social factors of what our patients are coming in with, the fear of the steroids. And that's probably like 95% of it, right? And then the 5% of it is actually deal with it. Yeah. So it's great to have your thoughts on it, because I think it'll equip everybody in clinic with some verbiage and ideas about how to kind of tackle the different scenarios, and in their brains how to kind of differentiate, well, maybe this patient really is having it versus, oh wait, no, they only use 15 grams. It's not possible. They're probably fine.
Yeah. So let's just go through the sort of like what I think most people would agree are some core aspects of what presenting signs and situations would be for something that's consistent with topical steroid withdrawal. And so usually, say if I have a scenario where someone used super potent topical corticosteroids on head and neck for months and months, and then stops them. So the findings can include confluent erythema, and that can be within days to weeks after discontinuing. There's a symptom complex that seems to be beyond that of just itch, with at least moderate rates of stinging and burning associated with it. The trickier part is the story that there can be escalating need for steroids, just sort of ramping up to higher levels of steroids. And that is the first part that can get really confusing, because there are patients who just use steroids to control their disease, but if they have their persistent disease, it comes back when they stop it. But going through the physical aspects, so you can have diffuse erythema and edema. Think of an arm involved, but often there's a sharp cutoff right by the wrist, which actually brings up the differential of the wrist of a hand is a differential of allergic contact dermatitis. But that's something that has been seen in multiple patients. And so it's considered to be a sign of topical steroid withdrawal. It's been called the red sleeve sign, where it cuts off at the sleeve. There's also another odd sign that's called the elephant wrinkles. And elephant wrinkles are like, think of like on the elbow, you get these diffuse wrinkles that are there. And I believe my interpretation is that these patients had a marked amount of edema as part of their withdrawal, and the next step after the edema is this sort of redundant wrinkled skin from that, which is different than like tanification, which isn't wrinkled. It's just thickened. And then you can get a lot of exfoliative change. So as we know, just like with withdrawal and psoriasis, with oral steroids, we occasionally see in atopic dermatitis a generalized erythroderma, and you can certainly get a lot of exfoliation. And there are a variety of names. One of them is called arderema, which is sort of supposedly it's a dull skin with scaling. And then people will show pictures of their scaling, diffuse scaling, which you'd say, wow, it's like an exfoliative a process going on with collections of scale, which is in the patient verbiage has been called snow. So there's these variety of features that may be associated, both the signs and symptoms with itch and burning pain, and then these variable signs besides just eczema with scaling, erythema, weeping. Of course, you can have atrophy with telangiectasia. And what's tricky, though, if you actually look at the literature, which we tend to do as nerds who are going to talk about a topic, it's inconsistent in terms of how common these signs are. So there have been several studies, one web-based study where they said, if you have topical steroid withdrawal, please fill out these materials of which signs and symptoms you have, and others that actually took a group of patients and studied them more carefully. One was a Swedish study, one U.S. There's really inconsistency in terms of how frequently these signs are there, but I still think that people should be aware of them. And if you're seeing a morphology that's different than your standard morphology, and then you query a history of extensive use of topical corticosteroids beyond what you think you would do, where you're doing them more, get it under control and then intermittently, otherwise bring a non-steroid into the regimen, because we do have those options. Then I think it's appropriate to consider topical steroid withdrawal. Having said that, I think messaging is confusing, because if I come up with a scenario where the messaging is, if the eczema comes back after you stop your topical steroids, that's topical steroid. That means you're addicted to them, or you have withdrawal phenomena. It's like, no, you just have eczema. You could have that, but most of the time we see that is in patients who just have persistent eczema, either because the degree of their eczema, that they're moderate or persistent patients, and or they're still being exposed to whatever triggers drive it. And so we're in the situation of sort of explaining that the disease course, which is variable in individuals, may not be that the next 6 weeks what happens is because they use steroids for a week. And that's part of it. trickiness of it.
That's so super helpful. Actually, like 2 patients of mine came to mind as you were describing that edematous kind of wrinkling that happens in the skin. Like 2 come to mind that I was like, is this lichenification? Because that's kind of where your brain goes to when your skin looks thicker. But your brain almost recognizes, because we've done so much pattern recognition over time, like it's not quite right for lichenification. So I'm like, oh man, maybe this is what they had. I'm gonna go back and call them. I'm gonna come back in and let's see how you're doing.
Yeah, there's probably a neuropathic pain element to it in the patients who truly have had the phenomena. And that's something, there's a hypoesthesia of the skin that may be beyond the normal, what I call twitchiness of a atopic dermatitis. Now, there's also been some confusing research. There was a group out of the NIH that sort of decided that they take a bunch of topical steroid withdrawal patients and do a metabolomics and transcriptomics of skin biology, and came to the conclusion that there's a excess of mitochondrial NAD plus as an etiology for this. They also came up with major criteria with burning, flushing, and thermodysregulation, and minor criteria, but it's been highly critiqued because it really was not an aggressively designed and it sort of, normal sort of high level clinical research, even though it was published in the JID. And then they did an intervention with metformin and also with berberine, which is similar medicine, thinking that they, saying that they had improvement, but again, there wasn't rigorous measures. So I think that's something that could be, if you have patients or you have a strong interest in this, you can go to some of that other expanded literature. From a more general standpoint, I think one of the issues we should have to be aware that whether we like it or not, a lot of patients have been reading about topical steroid withdrawal phenomena, and they come in loaded with those issues. I had a patient, it was an acne patient, 16-year-old acne patient, no history of atopic dermatitis, go through the whole acne thing, and she goes, oh, by the way, I have these bumps on my elbows, and it's very mild frictional lichenoid dermatitis. So I'm like, oh, that's a thing. It's called frictional lichenoid dermatitis. It's on the spectrum of eczema, but not really eczema. I can show you a picture of it if you want to see. It's like, if you want, we can give you a topical steroid. It usually melts away with that. She goes, well, I get steroid addiction.
Wow. Where had you, that's a 16-year-old.
Freaking acne patient.
The power of social media and getting your education.
So I do think so. So part of our, is that be aware of these discussions. If you do have patients who may have this phenomenon, obviously we have a lot of choices, but one of the things is that sometimes the interpretation of topical steroid addiction is that the doctors don't recognize this. And so I don't trust anything they'll do.
Right.
Do we have non-steroids we can use in place of that? Absolutely. And there are a few articles in the literature of using systemic dupilumab for topical steroid withdrawal phenomena with very good success. And now some of these patients can have very, very tough atopic dermatitis. I've seen one who ended up in my regular kid clinic, as it was a 24-year-old who definitely, I walked in and was like, this is what it is. And was reluctant to go on any therapy at that point. That's one of the things that you should be aware of, that in the world of topical steroid addiction, the group that helps to promote knowledge of this also has promoted, without good evidence, I'd say, that the treatment is withdrawal of all medication.
All medications, which is not, that doesn't sound right.
That's right. And actually, there's a video called Skin on Fire that you can find on YouTube, and it's worth actually watching. That might mean you'd have to hang at home and hide for 6 months.
That's
and maybe
terrible.
Give up your job.
Yeah.
Yeah, but that the body's going to spontaneously reboot.
Oh my goodness.
And that just brings so much potential complicating damage to a situation that's difficult, when I do think we have very good, effective, non-steroidal therapies, both systemic and topical, that can help both manage this phenomena as well as manage the underlying eczema.
That's definitely another gap then. We need to create some more videos describing this to patient facing as well. And in your view, what do you think is like kind of the best game plan when you do see and you're pretty sure this is topical steroid withdrawal? Do you still keep the steroids on board and transition onto something else? And is that something a topical or an injectable or?
So one of the most mind-bending parts of a recent study that did a survey is that it was, I forget if it was 30 or 40% of individuals were still using topical steroids, even though they had answered the survey that said that they had topical steroid withdrawal. So I mean, that's something where I say, fine, we can do without our topical steroids. I really try to counsel patients into systemic therapies, and depending upon how bad they are, I'd have my option of my traditional biologic, which would be dupilumab, my alternatives, which could include, Trelo, Levry, and Nemo, or an oral JAK inhibitor, which could be totally appropriate for, rapid change. And that'd be shared patient decision making. But that would be my course. Like, let's stay away from the topical steroids. We have other alternatives. While I wanted, we spend part of our lives defending steroids, and especially topical steroids, because we end up doing it. On the other hand, there's times where, in football analogy, it's just punt.
Yes, that's right.
So I don't need to convince someone, in that case, let's try
just
to counsel
switch
them.
over. And from a logistical standpoint, let's say you're going to switch somebody today, you see them in the clinic, and magically the dupilumab gets covered and they have it tomorrow, which is a very realistic situation. Our biologics are all approved in 24 hours, but they have it tomorrow. Do you have them physically stop all steroids, or do you do some period of kind of transition in between the two agents?
If they're used, no, I would probably taper them down, because we know with our biologic agents, they take a little longer to kick in, depending, of course, on where they are in their withdrawal. It's very interesting. I actually saw a JAK inhibitor withdrawal, which very much looked like topical steroid withdrawal.
Oh, interesting.
A patient who had severe conjunctivitis on one biologic. He was put on low dose oral JAK, but which didn't cover him. Then he was put on lebrikizumab, but they stopped the oral JAK probably a little quickly. He came in with like this edema and exfoliation, not quite erythroderma, that looked very much like that. And it was just that they had stopped the JAK too quickly, didn't give time for the biologic to work. So general trend would be take your time, whatever you're using, to start a biologic and or oral JAK, and then move your way down from the other. Because what you don't want, you want to minimize whatever rebound can happen as much as possible, because you know that person went through it. But lastly, a point is that if you have a kid with a family's concerned about topical steroid withdrawal, it's probably not topical steroid withdrawal. When I lectured at this at the World Congress of Peds, I'd asked how many people had seen a kid or a teenager that they really thought met the criteria, and there were maybe 3 or 4 hands out of 800 people in the audience. So there's much more hype than there is real commonality.
So you really need to be on it probably for decades, do you think? Like, kids are just not on it long enough, do you think? Or it's just that more the kids are different than adult skin?
Both kids are in a situation where someone's going to use clobetasol for 3 months in a row.
Maybe we're just not using it on a kid anyway. That's right.
Everyone's more judicious with kids than they are with them.
That's true. There's more refills on your steroid for an adult. You really think it through. So it's really just a practical dispensing is what the difference is. And do you find and then we do have a lot more options now as far as non-steroidal topicals. Do you feel like you've kind of changed your practice? And some of it is just logistically, you have to try a steroid before they'll approve the non-steroid. But if all that being aside, the insurance issues, do you find you're reaching for non-steroids more? Should we be doing that? Or are the steroids just the most effective still at the quick onset of action and relief? And
you can't take away the we've effectively used topical corticosteroids, and I've had it long enough, right before the turn of the century, right? We didn't even have, Pimicro and tacrolimus, right? So, but the broader set of non-steroids is changing practice, and as I say, we spend a lot of our time defending topical steroids, but a certain degree now and then it's like, are we defending them too much? And so, as long as access gets the drug into the hands of individuals, and because families they've always been steroid phobic, now it's like harder steroid phobia to deal with. I'm much more liberal at offering topical nonsteroids. And, the expansion is incredible, right? Topical Rux just got approved to age 2 with essentially the same safety data and with a really reasonable quantity of use for those patients, with the 20% body surface area. And then we know sounds like Roca's going to be approved at the time we're doing it. Could be already approved, any second now, down to age 2 years of age as well. So it gives us this expanded age of availability of our topical nonsteroids. So I use them a lot more in practice, if letting the family help to make that decision making. And certainly if we can't get by with hits of topical steroid and then discontinuous use 2 times or 3 times a week, I tell people if my steroids are hammers for eczema, I got mini hammers and I got big hammers and I got sledgehammers.
That's a good way to have it.
But then I got screwdrivers and pliers, so I'm happy to use the other tools.
I love it. Yeah, that's the best. Then we need to make that patient handout. That's the the different levels of construction work we need to get in with. But that's great. Thank you so much for this. It's super helpful. I personally learned a lot, so I know everyone listening is going to learn a lot too. It's definitely an area that we don't talk about as much, and we should, because it sounds like many others are talking about it on social media that are maybe not board certified dermatologists. And that study, I'll look it up too. I mean, although it just doesn't sound like the science was maybe super ironclad, but it's interesting, this kind of pointing maybe to some metabolic things with the mitochondria. Maybe there's some insulin resistance story there. I mean, who knows? We'll kind of find over time if there's these different pathways that are kind of involved. So it's just like on our nerd side, that's a fun thing to kind of follow the journals right. and see how it pans out.
Even the question, is that an innate thing, or is that something that happened after topical corticosteroids? We don't.
So that'll be really exciting to kind of see how it pans out over time. But thank you so much. And this is the Future of Derm podcast. So we always ask at the end, one or 2 things you're excited about in the future within this field, or anything else really. Any huge things coming up? Any major exciting things?
Yeah. So I mean, we're still at this point in atopic dermatitis where we're dealing with the relatively new use in the first few years of life. So it's still mind-bending. I think trying to answer the core questions of like, when should I start and how long should I treat for significant AD in the first few years of life? And how will that carry through to less eczema in the future and less comorbidities and other issues? That's the big question, which we're living through first by sort of using it and then figuring it out communally, as well as some ongoing, studies around the world. But that's still, I think that's the future for me. If I can turn off that eczema early and minimize the life impact on the individual in a safe and effective way, with a few years of treatment, I would love that. That'd be fabulous.
Oh, that'd be amazing. We can't wait to hear more about that over time too, as we find out more and more, because that is such a population that we're all like, should we treat? And then once you start treating, you start to see, yes, definitely, we should treat them aggressively and early, and all the sequelae that kind of come from them just being better and development and all the things we see in clinic.
Yes. And what should say, it could also be even in the milder patients, just getting more effective control with topical steroids and non-steroids. So pushing, when I see families who have really significant disease in their kid and they're waiting for the kid to outgrow it, it's like, the worse it is, the more chance it won't. Yes. So take the intervention. In that case, trying to impact on their future by better treatment when you're seeing them.
Absolutely. So, well, thank you so much. You're always so generous with your time, because we know you have a million things on your plate and you always take the time to educate all of us. Thank you so much again, Dr. Eichenfield. We learned so much today.
Thank you.
Thank you.
Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.